So I've been asked to talk about the basics in ophthalmology related to the MRCP. As you know, in this course, most of us are actually based in the UK, so I'm based in Glasgow, and I do teach for our college and also the Royal College of Physicians and Surgeons of Glasgow. I do examine for them as well. So hopefully we'll give you some insight as to what is necessary. So if you look at the first slide I have here, there's the eye is part of the orbit. And you need to remember that there are a lot of structures around the eye. We'll go into the structures of the eye just in the next slide. There's the extraocular muscles, of which there are 6. There's the superior rectus, inferior rectus, lateral rectus, medial rectus, superior oblique, and inferior oblique. Neuro-ophthalmology has not been, I have not been asked to cover today, so I will not go into nerve palsies and the neural attachments, but if it's required, I can do that at a future date. There's periorbital fat, and there is the preorbital septum. This comes in important for infections, which can spread from the eyelids into the orbital tissues. And then there's the bony orbit. The most thin part of the orbit is the inferior part, which therefore during trauma you do get to have blowout fractures or inferior orbital fractures. But most of my talk today is about the eye itself. So a little refresher into the actual structures in the eye. Right at the front, you have the cornea and the conjunctiva, which is the superficial covering of the. Then between the cornea and the iris. Sorry, do we have is there somebody wanting to speak? No, okay. Between the cornea and the iris, there is the anterior chamber. The anterior chamber is where we see cells and flare when we are looking for anterior uveitis. Then you have the iris, the ciliary body, and the choroid, which together form the uveal tissue, and that's the layer which becomes inflamed in the conditions that we call uveitis, which, as you know, have a significant association with the vasculitis and connective tissue disease. Behind in the middle of the iris, as you know, there's a pupil, and right behind the pupil is the lens. And there are some diseases that can manifest themselves in the lens. Behind the lens, there's the vitreous chamber, which is full of vitreous humor, and then comes the retina. The retina is specialized at the center of the fovea, which is the center of the macula. The optic nerve comes in slightly nasal, and it takes from the ganglion cell layer, it takes the nerves up towards the brain. And underneath the retina, you have the retinal pigment epithelium and choroid. The vasculature of the eye comes in through the neurovascular bundle from the optic nerve, and the retinal arteries, but they split into 4 quadrants. So we talk of the supranasal, supratemporal, infranasal, and infratemporal quadrants when we look at the retina. And the only other thing I haven't mentioned here are the zonules, which keep the lens in place and join them to the ciliary body. These structures are normally not associated with systemic problems, but they are important for when we're doing eye surgery. How do you assess the eye? Well, the most important thing to assess visual function is visual acuity. And visual acuity is classically tested in Snellen format, which gives you the number of meters that a normal person can see a letter compared to the distance you're standing at. So in most places we measure this at 6 feet. So 660 is the top line, 6'6" is normal line. Sorry, we measure that in meters, sorry, that's 6 meters, but in feet, that's 20 feet. So in the American system, that's documented as 20/20 vision. The 6 is standing for meters there. The other ways to assess visual function is to look at the pupils and look at colour vision. I think I don't have the other things here, but right at the bottom, the 12 there is part of the Ishihara plates. So you may have seen these Ishihara plates, which can give you an idea if the colour vision is correct or abnormal. When we look at optic nerve function, we need to do visual fields, we need to check for an afferent pupillary defect, and we need to do the colour vision, because those are all functions of the optic nerve. So you can have several places where the problem happens. Certainly, if there's a problem with your macula, which is the center part of the eye, then there will be a reduction of vision. And age-related macular degeneration is a very common cause in the elderly for reduced vision. And the picture on the left-hand side bottom there shows a picture of macular degeneration. In this picture, you see hemorrhage, you see exudate, which is the whitish area beside that. And in general, the structures are a bit blurred, which makes me feel there is fluid. And this is because there are neovascular membranes underneath the retina. They are called the choroidal neovascular membrane, which leaks fluid and blood and causes these changes to occur, which reduces the vision. It's very important to pick this up, this particular type of macular degeneration, as there are now effective treatments for this, and with effective treatment, patients can return some vision and certainly maintain their vision for long periods of time. The middle picture here shows a macular hole. This is an abnormality in the vitreous causing pull on the certain layers of the retina. And you see quite a large hole there involving the whole of the macula. There's a slight cuff round about the hole, which makes you think there's some fluid there. Macular holes are treatable in our day and age with vitrectomy and factors put into the eye, and the holes can be closed, and vision can be maintained and even improved. It does need to be done fairly soon after diagnosis, so that's something else we need to look at when we're looking for a reason for vision to be deteriorated. The right-hand side shows multiple nerve fiber layer hemorrhages extending from the superotemporal vein. So this is a macular retinal vein occlusion, and the hemorrhages reach the macula itself. There's probably fluid around the macula itself, and these vascular changes will cause visual damage. Some of this recovers spontaneously. Again, we have treatments available now in the way of intravitreal injections of anti-VEGF, which minimize the amount of damage that is being done. It's a classical picture of this sort of flame coming away from the center of the disc involving a quadrant. So it's really a recognition of this is the picture of a branch retinal vein occlusion. Very often patients do not recognize when one eye becomes damaged because they have the other eye and it compensates. For a patient with macular problems, they will have, this is an Amsler chart on the left-hand side, they'll see straight lines are distorted. So they'll see wiggly lines instead of straight lines. And eventually, as the central vision goes, they'll have a central scotoma, which is what you see on the right. They'll be able to see peripheral things, they'll be able to see objects, but they can't see fine detail, and they are unable to read with that eye. So what other problems can you have in the retina? So one of the causes of sudden loss of vision is central retinal artery occlusion. This is painless, it's sudden, and it may be preceded by amaurosis fugax, which is defined as the vision becoming black for a period of 1 or 2 seconds and coming back. The patient may have cardiovascular issues such as heart valve issues. They may have stenosis carotids. In fact, that is a test we would do. We would do a carotid ultrasound to check the amount of stenosis in their carotid arteries. And certainly in Caucasian populations, giant cell arteritis is a very important condition to rule out for patients over 50 years of age. There will be a relative afferent pupillary defect because there is a large amount of loss of retina. So in the pictures, these are showing various elements. In the first picture on the left-hand side, it shows pretty much a macular artery occlusion with a very good cherry red spot, lots of pallor around about it, but the rest of the eye looks pretty pink. So the central retinal artery supplies most of the retina, but the center of the retina has sometimes been supplied by a cilioretinal artery. So either you can get central retinal artery occlusion with sparing of the cilioretinal artery, or in this case, you can get just the center of it being involved. The right-hand picture is much more classical of a complete central retinal artery occlusion, as the whole retina is pale, but the macula is still cherry red. The one below that shows a hemi or a branch retinal artery occlusion. The pallor is in one quadrant, and this time it's the infratemporal quadrant. And the furthest inferior picture is showing emboli within the carotid, within the retinal arteries itself. So at the 2 points of bifurcation, there are 2 emboli present. These patients are treated at the same any other stroke patient is treated. We fast track them to the stroke clinic. They have full cardiovascular workup with carotid ultrasounds, and they are given as appropriate lipid-lowering medication or antiplatelet therapy as they would for any other stroke.